Again, hello everyone. This is Tranesh, and it's my pleasure having our second session with salivary gland unknowns. So let's start with this one. Everybody can see that this is anybody know what organ this could be? What salivary gland could be? This one. Let me a little bit make it horizontal, or maybe like this. So, okay, anybody feel free to write down what salivary gland this one could be. Okay. So yes, this is a minor salivary gland, which is important point here. Minor salivary gland means that if you have a cadaver and would like to dissect that cadaver, whether an autopsy or whatever, as major salivary gland, you can localize the gland anatomically. You can hold it and you say, well, this is parotid, this is submandibular, and this is sublingual. So they are major salivary glands. Minor salivary gland, you cannot. You cannot hold the tissue. They say this is a minor salivary gland, speaking like, gross examination. So minor salivary gland can be anywhere from the upper aerodigestive, in the nose, in the oral cavity, of course. It can be in the trachea, can be in the aerodigestive tract. So these are minor salivary gland, the tongue, everywhere in upper aerodigestive tract. Okay, so you cannot dissect them based on the gross examination. All right, so we are talking now about a minor salivary gland, and this could be around the lingual area, meaning that we have a lot of these with the buffer. I don't know, it's not buffering well. Well, we have mucinous secretion, yes, mucinous type of mucinous. Of course, when they expose to alcohol, they will be wiped out. Okay, so we have that here, and then we have this. All right, so again, it is kind of is it well circumscribed or not that well, or ill circumscribed, in your opinion? Yes, so it is kind of yeah, it is lobulated, but overall it is ill circumscribed. It's not going, so this from the get-go, kind of, we are suspicious what we deal is. It doesn't need it is high grade, because again we say that we have different criteria for some salivary gland tumors, but it looks like it is not normal proliferation. All right, let's see the component here. So what we have these, anybody like to describe what kind of cells they are, these here? I guess most of you by now know the diagnosis. So yeah, so I see some of you like to use squamoid. Yes, they are squamoid or epidermoid. They like the word epidermoid, and I will soon say why we are say epidermoid, to say squamous. Okay, and these are here, some of them here, like here, are the mucocyte or mucinous. Some of them, they are like starting to change. They have some secretion, and they have kind of the polygonal form that we call them so they are not epidermoid cells, not a mucocyte. What are the cells that in the middle? What are the cells in the middle between the mucocyte and epidermoid cells? What we call them? Excellent. We call them intermediate cells. Okay, so some of the pathologists, actually, the expert, they're not that much triggered, or they say, okay, well, this is I'm not that much, don't believe much of intermediate cells. Probably they are just squamous or epidermoid cells, that they are in different stage. But anyhow, They call them epidermoid cells, and we have squamous, we have mucocyte, and we have these intermediate cells. Okay, I agree with you guys. This is the mucoepidermoid carcinoma. Mucoepidermoid carcinoma. Okay. Can anyone tell me why I didn't jump and call it adenosquamous carcinoma? Like, first of all, what are two things usually? Two things I see in a squamous cell carcinoma that I don't see in a mucoepidermoid carcinoma. And virtually, if we see them in a lesion that we think they are mucoepidermoid carcinoma, if I see two things in the mucoepidermoid carcinoma, but basically it rule out the mucoepidermoid carcinoma and makes it squamous cell carcinoma. All right. So yes, one of them is keratinization. So I don't see, because these cells are not really squamous. They are, or epidermoid or squamoid. They are not real. Okay. So first of all, we see, or I don't want to see, and again, we don't say never, but I would say it is like one case that an expert will see, and it will be proven that it is mucoepidermoid carcinoma. So I would say for our level, never. But again, there is no never in medicine. So, but for us, as with people still working in our career, we say, if you see that, don't call it. You don't call. Don't, say, if you see keratin burls, don't call it mucoepidermoid carcinoma. Send it out to somebody who is really expert and see this is what they does all the time. For us, no, it is never. Okay, first one is keratinization. The second thing is, actually we see necrosis. We see necrosis in mucoepidermoid carcinoma. It's not something that, it is still cancer, and we may see. But usually we don't see intracellular bridges. Okay, intercellular bridges between these cells, because again, they are not really squamous cells. So they are squamoid. They are similar to squamous cells, but they're not really squamous cells. Okay, excellent. So intercellular bridges, we don't see that, and we don't see keratinization. And this is the more common scenario, to be honest. Like, most of the time when I got these cases, it's basically, it is a metastatic squamous cell carcinoma. Okay, so it is very rare to find primary squamous cell carcinoma. Most of the time, it is metastatic squamous cell carcinoma in a lymph node inside the parotid gland. Okay, so we know that minor salivary gland is the most common malignant salivary gland tumor, and that is for salivary major and minor salivary gland. Yes, it loves major salivary gland, but we see it in minor as well. And actually, in this case, it is minor salivary gland. But if it is a major salivary gland, like parotid gland, if I see a kind of squamoid area, most of the time it is metastatic squamous cell carcinoma. It is rarely to be primary squamous cell carcinoma. Okay, rarely to be primary squamous cell carcinoma. So this is like, the common scenario, and it is metastatizing in a lymph node, what we call intraparotid lymph nodes. Do you know roughly how many lymph nodes in the parotid gland? Anybody know any number, like how many lymph nodes we can have in a parotid gland? 1, 2? Just shoot a number. All right, so usually we get up to 20 lymph nodes. So many times, especially in children, they have this mass in the parotid gland. It's just reactive lymph node, and you do finite aspiration and you see these reactive lymphoid cells. Don't just jump into lymphoma. Okay, we can see a lot of lymph nodes in a parotid gland. Okay, all right. Now we go to the grading. That is actually what the surgeon will be waiting to hear. All the fancy stuff that I've been talking about, it is nothing for them. We really need two things. The first thing is the grading. All right, so anybody would like to grade it for me? Like, okay. All right, yeah, I agree with you. It is low grade. Based on what? Based on the cystic component, like what we have here. Cystic component. and we say it is like more than 25%. That is good cystic component, and it is low grade. This is the major component, but other stuff like that has we call it like upgrade the stage or the grade, and it is poor prognostic features that the surgeon will be looking for it into it. Anybody know what are the poor prognostic features that if we have them, this is not good? First of all, besides the cystic component is the mitosis. So we have to look for mitosis, and solid areas as well, mitosis. And mitosis, it is more than, anybody know how many mitosis is? It is not, yes, excellent. More than 4 mitosis per 10 high power field. The anaplasia or pleomorphism, and of course, if there is lymph node metastasis, usually we don't see that much, but patient age, of course, if patient is older, more probably will have more significant morbidity than younger, tumor size, and parenchymal extension. And we say from the last time, parenchymal extension, we put that grossly or radiologically. Okay, so of course the margins. So this is the other thing that the clinician will be looking at. Margins, I want it to be clear. And the other thing is the grade. So expect if you have a resection, you have to do both of these. And of course, we will be mentioning anything is abnormal. Like if we say low grade, you did your homework. It's not just you're saying that, meaning that you looked at the cystic component, you looked at the mitosis, you looked at the necrosis, at the anaplasia, anything out of ordinary, you have to describe that. If you have significant mitosis or necrosis or anaplasia or pleomorphism, all of that you have to describe it. If you say low grade, meaning that you are satisfied with the component that you have. Okay, all right. So let's see that you have small biopsy and it is in the lip. What is the differential diagnosis in the lip? If you have a small biopsy, something glandular, growing there, and it is more common in the lip. And it is not crazy. Yes, I guess you guys go with CA, which is we use for cancer, but it can be used as for canalicular adenoma. So sometimes just spell it a little bit out. It will be easier for the others. Yes, I agree. It's canalicular adenoma, and canalicular adenoma, it's not crazy similar to mucoepidermoid carcinoma. I mean, it's not something that easily fooled by. But sometimes if the biopsy, lip, nobody wants to have a big chunk of his lip. So yes, again, Ahmed, your excellent comment. It's about to come to it. But canalicular adenoma. The other thing is the mucocele. Good job. The mucocele, especially in the fine needle aspiration, and we got a lot of these. And there is retention mucocele and extravasation mucocele. And if you see mucocele or something that mucin secreting tumor or lesion, that's what we're going to call it, mucin secreting lesion, and say that low grade mucoepidermoid carcinoma cannot be excluded. Okay, and you have to be careful that especially on the fine needle aspiration. Actually, if it's resection, I guess you be bold and give it, this is mucocele with all the CD6 or mucocyte, positive mucocyte. But if you have fine needle aspiration and get a lot of mucin, you want to be sure that, or don't, even if young population, it's not, it can be having any age. Okay, all right. So let's see. Do you think immunostain can help with these lesions that you're not happy with or cannot really get into it? Well, squamous component, sometimes, you are dealing with the squamous mucosa. So usually you don't think canalicular adenoma, but anyhow, it will be some fragments of squamoid cells, especially it's fragmented mucocele or fragmented, usually lip biopsies are fragmented. So you just don't put your money on that part. Yes, so any immune stain you'd like to order? I mean, you can of course use mucicarmin for solid areas that you want to be squamoid area, mucosite, or mucicarmin can help. But immune stains overall, they don't help much. But what is important? Yes, rearrangement for mammal 2, mammal 2 rearrangement, which is translocation. Anybody knows what is the translocation? It is a translocation of chromosome 1190. Okay, so again, sometimes they will, it's 1119. They will ask you about that in some board questions. It is, they would like to order, they like to know how far you know. Okay, but mammal 2, please don't forget that. This is really important, the important one, very important. Okay. So we say the margin, the grade, these are the things that you have to check. Always check for any tumor, the regular thing, then the perineural invasion and everything else, like any other tumors, you have to put that, but expect that. Okay, so let's recap. This is a tumor that's the most common malignant salivary gland tumor with the wide age range, can be happening in children or elder. We say elder is bad. Usually it is low grade, and usually they don't metastatize. It can happen. I've seen cases, but usually no, especially with a clear margin. The histologically mucinous epidermoid and intermediate cells, you see them, and you would like to be sure that this is not a metastatic squamous cell carcinoma based on what we discussed, how keratinization and intercellular bridges, and usually with a clear margin patient, very good prognosis, really very good prognosis. Okay, and you have to comment, of course, on the cystic component. Usually you start with finite aspiration, which again, once you see any mucinous secreting lesion, you have to alarm the surgeons that we are dealing with something that it could be mucoepidermoid carcinoma, because the most common. So don't just put it into mucocele and that's it. All right, good job. All right, any question, anything regarding the mucoepidermoid carcinoma? It's very common in the exam. And I remember in my board, I gave me a slide with trachea and the lesion arising from the trachea, and it was a mucoepidermoid carcinoma. It was very cool. It wasn't the exam. I was just barely can swallow, but it was really, I enjoyed it in the exam. So this is mucoepidermoid carcinoma. All right, let's go with the next one if there is no question. All right, this is the most difficult one. You guys agree with me? All right, I'm gonna be a little bit mean because this is very common. So I'm gonna ask questions and some tricks. All right. So what is the most common benign salivary gland tumor? Well, I see Wharton tumor, and the answer is wrong. It is pleomorphic adenoma. If I asked what is the most common bilateral benign salivary gland tumor, the answer will be Wharton tumor. Excellent. All right. So what is the risk of Wharton tumor to be squamous cell carcinoma, to what we call the transformation, high-grade transformation or malignant transformation? What is the risk? Give me numbers. I mean, I know there is no real numbers, but I just wanna, I wanna see that it is almost near zero. Excellent. Yes, almost. And that, yeah, I know you will find some statistic. There is no, this is the average. I'm saying about the average. You will see some say, oh, I found something. It was called Wharton, then it become cancer. Probably it was cancer from the get-go. Just people, it is rare. Actually, almost zero. Okay, so based on that, the surgeon will be comfortable leaving it. This is the real story. So what is the population usually? Find it in male or female usually? Usually elder male with the habit. What is this habit? Yes, he is smoking or smoker. Excellent, smoker. Okay, let's see histologically. And do you know what kind of salivary gland usually we see it? You know what salivary gland this one is? Yes, so usually if you see an elder male smoker bilateral salivary gland lesion, it is the most common bilateral. It is usually 10% bilateral, not always, but you see them actually even unilateral can be multifocal. Okay, so you'll see some different and can even kind of between parentheses involve the lymph nodes. You'll see lymph nodes with these, Warthin tumor. I have not seen it outside the parotid. I don't know, to be honest. But this is usually the vicinity of the parotid gland, usually. Okay, so you'll see a cyst, papillary cyst, adenoma, lymphomatosum. That is the other word, okay? So papillary, again, we see a lot of these cholesterol clefts. Anybody know what are these? So these probably there's finite aspiration and there'll be areas of fibrosis. Here, hemosiderin macrophages, yes. But we see here some lining. Do you know what kind of lining usually we have? What is that? What are the changes that it have in the line here? Yes, oncocytic. All right. Do you know, guys, why there are oncocytic changes? Like usually, what makes the cells? What makes the cells pink? Excellent. So we'll see a lot of mitochondria. Okay, so usually mitochondria makes the cells pink. All right. So what happened here? It's basically because of the smoking, there will be a significant decrease in the aerobic energy process or synthesis, ATP synthesis, aerobic synthesis, and there'll be anaerobic. There'll be kind of switch into an anaerobic mechanism, and that will make trigger the gene to increase production of mitochondria. Okay, because of the smoking of lack of oxygen, and the mitochondria will increase, and this will be triggering the whole process, and we have these oncocytic features in the cells surrounded by lymphocytes. Okay. Again, if you give them finite aspiration, and it should be very nicely diagnosed by finite aspiration, this is Warthin tumor. If there is some changes, like sometimes we get some atypical changes, usually grossly we see this the cyst, and while we're finally aspirating it, it is like car oil used car oil material, so it is kind of dirty background in the finite aspiration, and this is kind of characteristic for that. That's enough. If you see some atypia, and sometimes we see some squamous atypia, it is basically from trauma, from whatever reason, you'll be very worried of. You see like dirty background, you think if it's necrosis, and some squamous metaplastic or atypical or dysplastic squamous metaplasia. What we're gonna think of in this circumstances that you are dealing with, you'll be thinking of metastatic squamous cell carcinoma, and that will make harm you. At least you will say, well, there is atypia, and the surgeon, okay, I'm not gonna risk it because both of them, one is benign, no problem. One is, okay, this is a big deal. Probably there's something. We're gonna just take it away if you're not comfortable. And well, sometimes cosmetic reasons, but usually it's elder population. They don't really care, and patients they cannot tolerate anesthesia. They will say, okay, just keep it. If it is straightforward case, just stay there. It's not gonna happen problems. Okay. All right. So I think this is overall what we get from a Warthin tumor. Again, we see oncocytic cells, papillary configuration, where there is cystic area and lymphoid aggregate, and it is related to smoking, the second most common salivary gland tumor after pleomorphic adenoma, or the most primary bilateral benign salivary gland tumor. Okay, and almost always exclusive in parotid. I never seen it again in outside the parotid gland, and simple surgical excision is enough for the case. Just be careful while you don't want to overcall it with any patient with some atypia. That's fine. We expect some atypia if everything fits. Okay, and patient will be like, surviving with no problems, even having it. Okay, and sometimes it happens if you find it aspiration frequently. Yeah, sometimes a bit pause because it is just the oncocytic variant or oncocytic changes will make it like hot. That's usually the problem with that. But if you comfort them with the finite aspiration, they will be happy with that. Squamous metaplasia like we have here, it can be seen, so don't just freak out. Maybe if there are some collection of these changes, you'll think of, okay, this, it's better to be got out. If you have a lot of atypia or a lot of mucus changes, you want to rule out mucodermoid carcinoma. But overall, don't just jump on one cell and that's it. Take the whole thing together. And radiological features also very helpful. Okay. All right, very good, very good. This is Warthin tumor. You can call it Warthins or you can call it Warthin. It's up to you. Both are correct. All right, good job, everyone. Next case. All right, next case. Let's go here. There are some areas of fat, and we have here something is not well. It's not going well. So there is. I hope by now you guys low power. If somebody give you this in the exam, just this picture, what's your diagnosis would be? All they give you this. Yes, ductal carcinoma in situ. Well, you can argue with ADH because I think this and this, it's enough to call it more than two to call it ductal carcinoma in situ. Okay, and that is a different discussion actually for DCIS versus ADH. Well, maybe one time we'll discuss it. Okay, so you have this. It is it looks like ductal carcinoma in situ, and once you have this buzzword, you are talking about, yes, you can talking about salivary duct carcinoma. Salivary duct carcinoma. It's kind of inherited to be a high power, high grade. It's like when you hear it, it's like high grade ductal carcinoma. This type, it's basically once anyone you tell that you don't like, it is for the clinician will be just, oh, this is a high grade, and this is something that you have to always emphasize. This is a high grade carcinoma. Well, there are some controversy. There are some low grade type or and being transformed. No, let's not go there. It is a high grade aggressive tumor. If somebody has it, so it is really need to multidisciplinary care and a lot of treatment. And if you cruise around, maybe you will find areas like here has some comedonic necrosis. You will find some very bad areas around. Okay, some solid areas becoming more solid, and it's filtrative, doesn't have a capsule. Okay, there is usually we don't see a capsule. Very poor prognosis, around less than 50% survival, 5-year survival. All right, so you will see a bunch of perineural invasions. You will see infiltration, and usually patient comes with pain and distortion of the area. Okay, all right. So we said it is high grade patient. We see areas of perineural invasion, lymphovascular invasion, comedonic necrosis, and cells like look atypical, very angry looking cells. Let's see the incidence. Thank God they are rare, kind of rare, less than around 10% of the malignant tumor, which always also rare, and sometimes de novo or sometimes pleomorphic adenoma. Sometimes carcinoma XPA, the carcinoma part is the salivary duct carcinoma, or it can arise de novo. Okay, if you have the whole thing, you can. Usually elder population, it's like 60s and 70s, so very important. And usually male, even it is like breast-like, but again, it is more male, from 2 to 4 times more than females. Okay. They like actually to discuss more the immune stains. Immune stains, anybody? What are the immune stain you shot? Number one, yes, it is androgen receptor positive. Almost always androgen receptor positive. Okay. The other immune stains, you can do CK7, which is, I guess, Ahmed, you're thinking of GATA, not GAGA. GATA tree. Yes, I agree. GATA tree, but you like to do 2 immune stains as well. They are CK56 and P63. Anybody knows why? Why we do this P40 or P63 and CK56? No. Because your top differential diagnosis is metastatic squamous cell carcinoma, right? So when you have something like that crazy, and it's not always, well, you will find small core biopsy or finite aspiration, and you see crazy cells, ugly, poorly differentiated. Sometimes it's not easy to call it from the get-go, oh, this is salivary duct carcinoma. You would like to go with the common thing, as I said, the metastatic squamous cell carcinoma. So don't just go with that fancy stuff and start doing all this. Especially androgen receptor is not on all places. You can find it in all places. So you would like to do it. You will do it. Actually, the oncologist won't let you go just without doing it. But you would like to start with the common ones, okay? And because it is it's different story. Sometimes it's metastatic, not primary salivary gland. You want to be sure that you excluded the squamous cell carcinoma. All right. Again, the other immune stain would like to order. Well, yeah, you can do the other kind of prestige. My mammoglobin, by the way, Fatima, is MAMMA, not mammoglobin. Okay, mammoglobin. All right. You would like to do other like PRST2, GATA tree. That's fine. It's okay. You would like to kind of support your case, but you can. Probably they will ask you, the oncologist. Again, I'm talking about the oncologist because he or she would like to treat the patient. He's looking for something, give him or give her the prognosis and kind of treatment modality. Even here, the treatment modality would be great for this immune stain, and the immune stain is HER2/neu. Okay, you can do HER2/neu. It can be, even it's not that much of an impact because they are really aggressive tumor. They won't just go, but you will ask you for AR and HER2/neu stain. AR, you can do what we call androgen deprivation therapy. Okay, so you try to decrease the level of androgen so the tumor won't get that thriving on that androgen receptor. HER2/neu, again, it's not as great responder therapeutic, but probably they will ask you to do the HER2/neu. Okay, and you will comment on that. The other thing you have to know is the poor prognostic indicators. Anybody know any poor prognostic indicator? Excellent. Size. And what size usually? Usually the size, if it is more than 3 centimeter. Okay, so more than 3 centimeter, and if there is positive margin, it is, again, this is bad prognostic. Of course, for tumors like lymph node metastasis, lymphovascular invasion, and perineural invasion. What about HER2/neu overexpression? Is it good or bad? HER2/neu. Is it good? or bad prognostic indicator? Amani, well, it is very diplomatic answer, Ali, and I agree with you. I mean, it is not that good for therapy, unfortunately. So it is a bad prognostic or poor prognostic indicator having HER2 overexpression, meaning that this tumor is really know how to defeat the cells and protect himself against that. Okay, and how to work to proliferate. Okay. The bad news that even okay, so there is HER2 overexpression, and you will try to give the patient some therapy like trazumab or Herceptin, the generic name, but won't be as a good effective. This Herceptin treatment won't be as good as breast cancer. Okay, so here the tumor is very aggressive. It's not like the breast cancer. All right, so we said it is poor prognostic factor having the HER2 overexpression. Okay, again, the local recurrence up to 50% of the time. It is very aggressive tumor. Usually patient die within, half of the patient die within 5 years. Half of the patient die 5 years, and usual lymph node metastasis will see that actually 2/3 of the patient will be having a lymph node metastasis at the time of the presentation. When the patient comes for resection, the patient will be almost have lymph node metastasis. Okay. There is 50% loss in PTEN, P10. Sometimes ask you about the molecular P10 loss, and sometimes you want to be sure that this is not carcinoma X pleomorphic adenoma, so you can do the pleomorphic adenoma marker, which is BLAG1 pleomorphic marker, BLAG1. You do that in case that you couldn't see that much, but again, it's not something that we exercise every day, or even this case is not that much. Usually we get them as a consultation from other smaller community hospitals, and the patient is seeking further treatment. So it will be like in some rural area, not in the not in the big cities around, small hospitals around us, and patient will be seeking primary care physician, then they will be doing biopsy, and we get the consultation and we confirm that, then we'll start the whole dilemma of how to get the resection. Usually the surgeon will sacrifice the facial nerve, and there will be a really radical dissection with lymph nodes, neck dissection as well, and we get like 2/3 of the patient will be lymphovascular invasion, lymph node metastasis, and we see a big chunk with perineural and lymphovascular invasion. Okay, so again, it's bad thing, unfortunately. Okay, any questions so far? All right, so this is salivary duct carcinoma, bad prognosis. Let's go with the next one. And okay, I'll give you like 5 seconds to sink in. Some people, I know, sometimes buffering, but I want you to scan the low power and tell me which part of the body, which part of the oral cavity I'm dealing with. Okay, so this, I'm sure whoever will be giving me the answer, I can say he is ready for the boards. Excellent, SK, excellent. And you are ready for the board. Congratulations. All right, so this is a ballot, unless if you already did your boards. This is the ballot here. You see the mucosa, all right? Sometimes it is kind of keratinized, especially in the hard ballot. And we see this submucosal proliferation. Okay, it's basically blue cells. All right, and blue, basically, when we say blue, we are dealing with cells that they are not really caring, or they don't care about secreting matrix. Okay, so these are a type of cells, they kind of matrix poor. They don't secrete that much of matrix. They just like to grow. the cells grow. Okay, and the striking feature here, they are monotonous. Well, they have enough cytoplasm actually to call them mesoid. So probably I won't use this word here in this particular, because you see there are some cytoplasm. It's good. NC ratio is not that crazy high. So it has cytoplasm. The striking feature is, I'm sorry, I can't get higher power than this, but the chromatin is kind of vesicular and open chromatin. Okay, vesicular and open chromatin. There's one thing I would like to show you. It is this. Anybody know a magic word? Yeah, excellent. So I say that some new people say targetoid appearance. I agree. I usually like to use the fancier word. Anybody know what is the other fancier word for this area of growth, how they are growth or growing? Yes. I see hurricane, I see an eye, I see storm. Can you guys make it one word together? Yes, an eye of the storm. Okay, the eye or an eye of the storm. Eye of the storm. And the eye of the storm, always remember, the easiest thing to remember is the, Jupiter. They have a big storm. I think some people, they say it is by the age of the Earth, and it is a huge storm. Okay, in the equatorial of the Jupiter. So we remember that. You'll see it's look like this one, huge in the atmosphere of the Jupiter. Okay, the eye of the storm. All right. So there are some buzzwords I just talked about. First of all, it is the ballot. So this actually a question: what is the most common minor salivary gland tumor? I want answers. What is the most common minor salivary gland tumor? I see Ali said mucodermoid carcinoma. ACC, I guess that's for adenoid cystic carcinoma. Okay. And I am sorry that I tricked you that it is still pleomorphic adenoma. Excellent, Primala. Yes. So I'm talking about salivary gland tumor. I didn't say what is the most common malignant minor salivary gland tumor. If it is malignant minor salivary gland tumor, it would be adenoid cystic carcinoma. If it is the malignant salivary gland tumor, it will be mucoepidermoid carcinoma. And if I say what is the second most common malignant minor salivary gland tumor, it will be what is the most common, what is the second most common malignant minor salivary gland tumor? That would be actually it will be the polymorphous low grade. Okay, so I know it is very confusing, but please focus on the exam, on the line. If they benign, if they bilateral, if they minor, if they say malignant, all of these are, you can get it, but just take a second, pause. Don't just jump onto it. So the malignant, if the question is what is the malignant salivary gland tumor? The most common malignant salivary gland tumor, mucoepidermoid carcinoma. What is the most common malignant minor salivary gland tumor? Is adenoid cystic carcinoma. What is the second most common malignant minor salivary gland carcinoma? It is pleomorphic low grade adenocarcinoma. By the way, this name, what I said, is being changed. Not this. It is not what I said exactly. It's not polymorphous low grade anymore. We'll discuss that with what is the new changes in WHO. If they say most common salivary gland tumor, it is pleomorphic adenoma. If they say what is the most common bilateral salivary gland tumor, it is a Warthin tumor. Okay, so always there are some tricks. All right. So this is second most common intraocular minor salivary gland tumor, and basically the buzzword, if they say ballot, the patient has a ballot lesion, just go with that. Does that mean ballot doesn't have another tumor? No, Actually, the more common in ballot, I just had one last week, it is adenoid-cystic carcinoma. But if they say ballot, keep your radars are like, okay, this could be polymorphous low-grade adenocarcinoma. It just get in the minor salivary gland. And ballot is around 60%. Okay, 60% of the time is the ballot there. Okay, it can happen in other places, minor salivary gland, but usually at the ballot. Which is usually it is low grade-ish. It's not that crazy. It's just good resection. Patient will be surviving well. There is no capsule. The problem you have to get very good, and you have sometimes to sacrifice the hard ballot, meaning that will be a resection, bone excision, and you have to fill that bone. Okay, so usually again unencapsulated, infiltrative pattern. And there is again targetoid or eye of storm appearance, or rarely used word appearance. The cells are polygonal, monotonous, open chromatin, vesicular chromatin. Tumor markers or immunostains it's not specific, so it won't be helpful that much. So it can be B40 or B63 positive. It's not that much. Very good prognosis overall. Local recurrence around 15% of the time. So just try to exclude the other lesions and prove this is especially the squamous cell carcinoma. You can do P40 usually negative, but P63 it's not exclude. It's not. It doesn't exclude squamous cell carcinoma because P63 is positive. Okay. All right. So the translocation can be found in the chromosome, the 12, long or short arm, but it activating the mutation for PRKD1. Remember that PRKD1 can be seen. Okay, your challenge, especially in small biopsy, to exclude adenoid cystic carcinoma and adenoid cystic carcinoma. Again, you can do the immune stains for that. MIB1 to exclude it. It's not much of highline material or matrix to start with, but solid areas of adenoid cystic carcinoma and basal cell adenoma / adenocarcinoma is also. So sometimes we just say low grade, if you don't have much, you can use basiloid. Either I don't like to use that if it is more obvious, but you can use if it is kind of not secreting that much, and recommend the full excision for that. All right, so canicular adenoma can be the way of trabecular arrangement, and usually it's in the oral cavity. And to be honest, if it's not resected, the whole thing not resected, I will not be comfortable calling it. Salivary gland, and if we may do some derm bath next sessions, if we arrange that. Adnexal tumors, it's like, it's kind of the rule of thumb. Adnexal tumors, remove them all. First of all, you don't know if you left some of the tumor in the body, how that would be, because usually if there is cancer, there is a benign component. If you got the benign component only, you would call it benign, and the malignant component will be still inside the patient. Okay, this is one thing. The other thing, there is a tendency for the this adnexal / salivary gland tumors to transform. After a while, benign, boom, it changes to malignant. And that even happen in some endocrine tumors like thyroid. Patient have biliary thyroid carcinoma. After a while, it will be anaplastic. Can you believe it? Cancer changing to upgrading to another cancer. Okay, so you won't be comfortable having any salivary gland tumor. Still, you want to clear margin, either benign or low-grade malignant. Okay, of course, if it is high-grade malignant, you need radical excision, not just that. So the new name by the WHO, and I heard this from Dr. Thompson, it is polymorphous adenocarcinoma, low-grade variant. Okay, maybe they saw some high-grade variant. They don't want to say low-grade polymorphous low-grade adenocarcinoma high-grade. That doesn't make sense. So they call it polymorphous adenocarcinoma low-grade variant. Okay, low-grade variant. Slow-growing, non-tender mass, usually not secreting matrix. It is easy-going tumor. Okay. All right. So this is unique tumor again. the eye of the storm. Excellent. Any question or comment so far? We'll go probably, this is our last lesion for this session. I can go with any question if you guys, or we can later on after finishing the whole session. Okay. Exactly. That's why Ali, they changed the name. It is like vast majority is low grade, but just they don't wanna use this. So say polymorphous adenocarcinoma, low grade variant. Okay, so it's not low grade or polymorphous low grade. It's not part of the name. Just they say it's low grade. All right, good job. Again, we are dealing with another salivary gland lesion. It can be seen for perineural invasion. It's not common. It's not something that you'll be surprised to see it, but also I won't be that much surprised if I didn't see it. So I won't really kill myself on perineural invasion. Usually you don't see it much. Okay. Okie dokie. All right. So this is a next case. Again, it's salivary gland. It is capsulated, and sometimes it has very. I remember a case I have in a few months ago. Most of the lesion is fibrotic, like barely you'll find some areas. It's like even falling apart. The area is proliferative. It has this. I think it has some of deal with some cytokinase or something that the tumor or the body is reacting against, and start or initiate fibrotic reaction. You will be surprised how cancers are smart. I told you that I did master's degree in Ohio State University in molecular pathology, and we had a big course called cancer biology. And cancer cells are very smart. Actually, they outsmart the human body cells, the regular cells. They do stuff. It's crazy. It is like, oh my God, they are so smart. How can they figure it out? So you will be impressed. I was very impressed when I took that course, the cancer biology, and how they have mechanisms and tools to to overcome the war. So our fight is not easy fight, and thanks for everyone who were working to be a help to defeat this bad thing. Okay, let's go to the meat now. I saw some people, they say secretory carcinoma. This is a good observation. But if you go to high power, actually, I think you'll be changing your mind a little bit. So if you have this picture, what do you think? What is the word you'd like to use? I want word like description, not shooting to the diagnosis or my. I agree there are some myoepithelial cells, but would you use a descriptive word here? Like this is the nature of the cell. Nature of this tumor is monophasic or biphasic. So Mariam described it well, but I want to shoot one word. It is biphasic, exactly, and it has glands with the clear cells, and it has these. I usually describe in myoepithelial cells like a kid who was drawing and then he got the rubber and would like to wipe that drawing. So it will be like something that it's been a little bit wiped. It's not clear. It's like watershed, it's not something shiny. It's kind of something watershed. It's not. That is usually the myoepithelial cells when you see it. So when you have something like a little bit hyalinized, which is what the differential diagnosis for this tumor, hyalinizing, think of this. So this is epithelial, myoepithelial adenoma or carcinoma. Looks very bland, huh? There is capsule. Yeah, there is capsule. So you would call it epithelial, myoepithelial adenoma or carcinoma. Yeah, actually, in this entity, you will find that not always there is a counterpart, meaning that I don't think there is a epithelial myoepithelial adenoma ever. I think there is epithelial myoepithelial carcinoma only. And that is the same for acinic cell. There is no acinic cell adenoma. There is acinic cell carcinoma. So even myoepithelioma is not a benign thing. It is. You have to deal with it as a carcinoma thing. Okay. All right. It is kind of changes, and it's basically kind of philosophical. So you won't want to go there. All right. So this is epithelial myoepithelial carcinoma. Okay. Epithelial myoepithelial carcinoma, and it is. Do you think, guys, it is common or uncommon tumor? Yeah, it is very rare. It's around 1% of all salivary gland tumors. Very rare. I've seen in the last 2 years two cases, epithelial myoepithelial carcinoma. They are not that common, and I do a lot of head and neck. So basically, you'll see again, you'll see two component. You'll see cuboidal columnar cells, clear changes. The clearing, is it fat or what? What makes the clearing in the cells? Excellent, Mariam. Glycogen, yes, glycogen. And that's why some people, they would call it glycogen-rich adenocarcinoma. Okay, so this, you'll find that people change that to glycogen-rich. But again, don't use that. Say just epithelial myoepithelial carcinoma based on these two, usually similar male and female, very slightly more common in female, and usually we see it in minor or major salivary gland. Actually, we see it more in major salivary gland. Yes, major salivary gland. It's like most of the time it's in parotid gland. Okay. However, it is very rare. Like the publication is not that much here. It is very slow growing, and again, it can present de novo or from pleomorphic adenoma, so carcinoma XPA. It is just, enjoy it when you see it. If you have a case like this, just enjoy it. You don't see it as much. You show it around, you do your, look around, see the lymph node metastasis, if there's anything. But usually, if the lesion has clear margin and there is no high grade transformation, which the problem, it happen in 20% of the time, high grade transformation. So be careful that don't miss. Submit the whole lesion, just go through it. Be careful with the margins. The markers for myoepithelial marker will be positive, so that's helpful. But morphological features is the most common. Okay, exclude the common ones. There is the HRAS mutation. It can be seen. Okay, welcome, Wafa. So this is the Wafa. This is the case that we have with epithelial myoepithelial carcinoma. All right. Any question about this? So usually myoepithelioma will see mostly myoepithelial cells, and actually we have a case. So let's discuss that, Chris, when we get into it. Okay. So myoepithelial cells can be different phases, faces. I mean, you will see it like spindle cell. You will see like plasmacytoid. You will see that hyalinized like this. So it is not an easy question. It can be again, can be clear cells with that. So when we see it's you see this biphasic proliferation like this, and it is kind of characteristic when you see it like this. It is the epithelial myoepithelial carcinoma. Does that mean that if you just call it myoepithelioma, you are wrong, like completely wrong? No, some areas you will just be very heavily, like here. This is some myoepithelial cells. Maybe if you have a core biopsy from here, that's what you're gonna call it. Almost similar to the prognosis. Just keep clear margin, and patient probably won't see him again or her again. Okay. All right. Any other question, guys? So it's 11 o'clock my time. Thank you so much for this rich discussion. It was great session. I'm always available for any comment or any questions, and I will send the link as well to Dr. Angie.